a 3-month-old male child who presented with progressively deepening jaundice since birth. The child was born with no significant antenatal or birth history. The birth weight was 3 kg and the present weight is 4.8 kg. On examination, there is no anemia, the liver is enlarged 4 centimeter and there is no splenomegaly or ascites. So here, what are we dealing with? What is the likely diagnosis?
I think that's very simple. The broad diagnosis should be waiting neonatal cholestasis, hypothyroidism. Let's have a broad diagnosis, not straight away jump to hypothyroidism. Yes, cholestasis is fine. That's all we can gather here. Cholestasis or biliary atresia. Okay, so there is a differential of cholestasis or biliary atresia. Whatever it is, finally it is leading to cholestasis only. So cholestasis, the next question, Dr. Dheeraj has already given it there, whether it is neonatal hepatitis or extrahepatic biliary atresia.
So now this answer I want, we know that you are dealing with a neonatal or infantile cholestasis syndrome, and now we need to distinguish between neonatal hepatitis, that is causes which are metabolic, infective and idiopathic, versus EHBA, which is mainly an obstructive cause. So what are the clues in this case which suggest one or the other diagnosis?
So far all the votes are for EHBA.
Then why?
Can be both. Because there is clay colored stools and there is normal weight gain. That's why they say clay colored stool. Consistency of liver is consistency is not mentioned. Okay, we just say enlarged. So you like to know the consistency, progressively increasing jaundice. That's why EHBA. No spleen. That's why EHBA. These are the various justifications for EHBA. EHBA, clay colored stool, enlargement 4 centimeters. So Dr. Dheeraj, these are the various justifications for EHBA, apparently healthy baby.
Yeah. So yes, so there are more clues towards the possibility of EHBA, but remember here in medicine there is nothing, that nothing is perfect. You can have all these features, you can still have a neonatal hepatitis. On the other way around, you can have everything with favoring a neonatal hepatitis, but it may turn out to be EHBA. So you have here a child who was normal birth weight in neonatal hepatitis most often, especially because of the perinatal infection. You may have child with IUGR, low birth weight. The child who is having neonatal hepatitis would have failure to thrive, whereas EHBA, especially during the first 3 months, they have normal growth, and when the portal hypertension and malabsorption sets in, then they have impaired growth. The jaundice is intermittent in neonatal hepatitis, whereas in EHBA it is progressively deepening, worsening jaundice. Acholic stools would be present in both, clay colored, but here in EHBA you would have always persistent acholic kind of stools, whereas in neonatal hepatitis you would have waxing waning, intermittent clay colored stools. In neonatal hepatitis, you say mainly hepatosplenomegaly, whereas only hepatomegaly in the initial part in EHBA, and the splenomegaly occurs when there is onset of portal hypertension due to cirrhosis. Then there are clues in investigation. If you perform an ultrasonography, you may have absent or non-visualization of the gallbladder in EHBA, whereas gallbladder may be normal or distended in neonatal hepatitis. Confirmation definitely is by more invasive methods. It can be done by liver biopsy, and sometimes during the operation for EHBA, everybody who operates EHBA, they have to do a peroperative cholangiography and see if there is excretion of dye into the bile flow into the duodenum. If there is a bile flow, they close the abdomen, do not operate. So, as I said, that the final diagnosis is established on the operative table, and it's a spectrum. So, what is neonatal hepatitis today may become EHBA later, or what you had in EHBA at the presentation, it could have been a neonatal hepatitis in the intrauterine period. So, these are overlapping diseases, but for management purposes, it is important to determine whether you are going to do the surgery or not. That is why the diagnosis has to be established before surgery. And definitely even at the time of surgery, you need to confirm that you are not dealing with a disorder where there is a flow of bile which is maintained.
Okay. So for the postgraduate, the first query was that this is what is this? This is infantile or neonatal cholestasis. The next query was whether it was neonatal hepatitis or extrahepatic biliary atresia. And obviously, once this is over, the examiner is going to ask you, what do you think are the causes of, if it is hepatitis, what are the causes of neonatal hepatitis in this child? So can you just quickly write down various, there are so many causes under so many heads. So just I think 10-20 causes of neonatal hepatitis will do. So please start writing. Intrauterine infections, congenital cytomegalovirus, galactosemia, torch infection. Don't repeat torch infections. Abhi to do hi aaye. Which amongst torch, which infections are most likely to give rise to neonatal hepatitis? Fructose intolerance. So you have metabolic causes, sepsis. So you have intrauterine, post-uterine infections. You have metabolic causes. CMV and rubella are more likely to give rise to neonatal hepatitis. There are several other metabolic causes also that can give rise to neonatal hepatitis. So just go and read. We are not going to give that list here today. It's a big list given in any of the in the PG textbook or in the Nelson. The list is there. Please go through it, and because you will have to tailor your differential diagnosis and tell the examiner mitochondrial hepatopathies, congenital syphilis is coming up, herpes. Okay. Dr. Dheeraj, anything to wind up the case?
I'll just add that in our time when we were reading, the majority of the neonatal hepatitis used to be comprised of idiopathic neonatal hepatitis. Now this idiopathic is shrinking. Previously, we used to be taught that about 60 to 70% of the neonatal hepatitis are idiopathic. Now that has shrunken to about 40%. So with more and more disorders being recognized, especially metabolic disorders, genetic disorders, disorders of the disorders with the bile flow, biliary metabolic disorder, especially PFIC. So all these, this idiopathic group is shrinking, and I'm sure that in next 20 years it will go down to 0%. Every neonatal hepatitis has to have some cause which is not recognized now. So this is I would say, dynamic thing. You need to know about the updates which is happening in a respective field.